So you're rounding on your patient and you see it again. Their creatinine has crept up another zero point 0.1. There's no obvious cause, nothing that jumps out at you. It is such a common, nagging problem on the wards, right? Well, today, we're going to explain one of the most important and honestly, often overlooked causes, chronic tubular interstitial nephritis.
Let's start right there. With that exact clinical scenario, you've got a patient, their creatinine is just slowly climbing over months. And the usual suspects, they just don't seem to fit. So, what's on your differential diagnosis? By the time we're done with this explainer, I guarantee you that chronic tubulointerstitial nephritis, or CTIN, is going to be right near the top of that list. First things first, we need to make a really crucial distinction here. We are talking about chronic TIN, which is a totally different beast from its acute cousin. You can think of acute TIN like a sudden fire. It's a rapid allergic reaction, it causes a ton of inflammation and swelling. Chronic TIN, on the other hand, is more like a slow, smoldering ember. It's this process of irreversible scarring and fibrosis that just builds and builds over months or even years. So, here's how we're going to crack this case. First, we'll talk about why it's such a silent disease. Then we're going to go inside the kidney to really see the damage. After that, we'll hunt for those subtle clinical clues, we'll line up the usual suspects causing it, and finally, we'll walk through exactly how to make the diagnosis and close the case with a right management plan. Okay, let's jump right in with the first big mystery. Why is this such a silent disease? Part 1 is all about that slow, insidious rise of creatinine. Now, here's what makes this disease so incredibly challenging. For all intents and purposes, it's a ghost. See, our kidneys have this massive functional reserve, which means a patient can lose a really significant amount of kidney function without feeling sick at all. And that's exactly why CKD so often flies completely under the radar until the damage is already pretty severe. So if they don't feel sick, what are the breadcrumbs we need to look for? Well, you'll see that rising creatinine on their labs for sure. And if you ask the right questions, they might report polyuria or nocturia, having to pee a lot, especially at night. And that is a huge clue. It tells you the damaged tubules are failing at one of their most important jobs, concentrating urine. But here's the real kicker. Their urinalysis might be frustratingly bland, without all the blood or protein you'd expect to see in other kidney diseases.
Okay, on to our next section, part 2. Let's unpack the damage. What is actually happening inside the kidney?
So, what's going on at the microscopic tissue level? The key word here, the one to remember, is scarring. Just imagine the interstitium. That's the delicate supporting tissue that sits between all the kidney's filters. Imagine it slowly being replaced by this rigid, useless scar tissue. And as this fibrosis takes over, the tubules themselves start to wither and die off. That is the engine that's driving the slow, relentless decline in kidney function.
Okay, so we know what's happening pathologically, but how do we actually spot this in the clinic? Let's move on to section 3, finding those clinical clues.
And here is a major clinical pearl for you. When the glomeruli, the main filters of the kidney, when they're damaged, they can leak massive amounts of protein into the urine. But CTIN isn't a disease of the filters. It's a disease of the tubules and the interstitium. And that means you get what we call low-grade proteinuria, almost always less than 1.5 grams a day. So if you see a urine sample just loaded with protein, you probably need to look for another diagnosis. And if we dig a little deeper into that tubular damage, you might uncover this classic constellation of findings called Fanconi syndrome. This isn't some separate disease. It's a direct consequence of the proximal tubules failing at their number one job, reabsorption. So what does that failure look like in the lab results? Well, first, you'll see glucose in the urine, but with a totally normal blood sugar. That's because the tubules just can't reabsorb the glucose they've filtered. Next, the kidneys start wasting phosphate and bicarbonate. And that wasted bicarb is key. It leads to a normal anion gap metabolic acidosis. When you see this weird cluster of lab findings all together, it is a massive clue that's pointing you directly to severe tubular damage.
All right, this brings us to the real core of the investigation. Let's get into section 4, a lineup of suspects and uncovering the cause.
So the list of potential causes is, well, it's vast. So it really helps to think in categories. Medications are the single biggest player, by far, accounting for about 40% of all cases. After that, you've got immunologic diseases, infections, and then a whole grab bag of other metabolic and systemic issues. Given that they're the biggest slice of the pie, it just makes sense to start our investigation with the most common culprits of all, medications. Okay, this is a super high-yield list for any trainee.
A key risk factor is long-term exposure to drugs that can cause acute interstitial nephritis. So you should always be thinking about analgesics like NSAIDs, common antibiotics, and especially proton pump inhibitors. So many of our patients are on those. And in specific populations, don't forget about lithium for bipolar disorder or calcineurin inhibitors like tacrolimus in our transplant patients.
All right, let's move on to the next major category. Next up, what happens when the body starts attacking itself? We're talking immunologic diseases.
A lot of systemic diseases can target the tubulointerstitium. Your classic autoimmune culprits include Sjogren's syndrome and sarcoidosis. Lupus can also cause TIN, and sometimes it does it without major glomerular involvement. But remember to think beyond just autoimmune disease. You got to consider infections like BK virus in transplant patients, or even infiltration from malignancies like lymphoma.
So, with all these clues and all these suspects, how do we actually confirm our suspicion? Let's move to Section 5, making the diagnosis and going from suspicion to certainty.
The workup here is a pretty logical pathway. It all starts with you being a detective. You have to take a meticulous history of every single medication, every supplement, every possible exposure. Next, you get the labs and the urinalysis to hunt for those subtle clues we talked about. An ultrasound can help assess for chronicity. In really advanced disease, the scarring often causes the kidneys to become small and bright, or echogenic. But at the end of the day, to get a definitive answer and actually see the fibrosis for yourself, the gold standard is a kidney biopsy.
Okay, you've done the work, you've made the diagnosis, now what? Let's wrap up with Section 6, closing the case, with the principles of management. The management strategy is guided by one simple principle: treat the root cause. If it's a medication, you have to stop it. If it's an underlying immunologic disease like sarcoidosis, you treat that, often with immunosuppression like glucocorticoids. And while you're tackling the primary cause, you're also providing that crucial supportive care, controlling their blood pressure, managing any metabolic issues, and just making sure there's no urinary tract obstruction.
We have covered a lot of ground here, from the nitty-gritty pathophysiology to a long list of causes and the steps for diagnosis. So if there is one thing, just one single thing you should absolutely take away about chronic tubular interstitial nephritis, what is it? It's this, right here. This quote is everything. Your job isn't just to manage a rising creatinine. Your job is to be a detective and find the underlying driver of the problem. Because it's only when you find and treat that true culprit, whether it's a drug, a systemic disease, or some other exposure, that you give your patient the best possible chance to halt the scarring and preserve their precious kidney function for the long term.